This is an age-old question within the US, trying to manage healthcare spending and providing high quality care at the same time. But over the past 50 years, there have been a lot of unique and interesting ways to attempt to solve or address this issue. Different solutions have come and gone based on public policy or kind of what the creative solution is at the time. Lynn, is one of the attorneys who's been at EBG since the firm's early days, what would you say has been EBG's legacy in connection with the U.S. tackling this problem that Mark laid out for us over the past 50 years?
Well, when Stephen Epstein founded the firm in 1973, the Medicare and Medicaid programs were less than 10 years old. Can you imagine that? And health insurance was predominantly indemnity. There was no such thing as PPOs or UROs or any kind of care coordination or even prior authorizations. Our audience might not know this, but our roots stem from helping to implement the federal HMO Act, which was enacted in 73. Ted's father, Senator Ted Kennedy, was the principal sponsor. Richard Nixon was the president coming from California. He was familiar with these entities. Department of Health, Education, and Welfare engaged EBG to help create a state regulatory framework for model acts so that entrepreneurs could create these entities depending on grant and loan money. And when that program ended, we ended up converting many of them from nonprofit to for-profit so that they could continue to get access to capital and continue to grow. Over all these years, first of all, they go by so quickly. What are some of the lessons learned? In my view, the private-public partnership that we have in the U.S. market is a very unique footprint. Outside the United States, many countries start with a fully public program. And yet, over time, these almost 50 years, I've seen those countries begin to put private sector initiatives in because the public sector alone cannot be efficient or provide the innovation. And here in the US, we started as a private initiative for health benefits, and the government stepped in those areas where our market was not working, such as for our senior citizens and our more indigent population. So where are we now? We have hybrids, some managed care, some choice. These tight integrated delivery systems cannot cover our entire country because we really have some very difficult supply side challenges. Not enough hospitals, not enough doctors. And we're all still trying to manage or coordinate care and shift or share risk. But we now have better access to data and technologies. What I'm seeing is that we're trying to spend the money on the right cohort within the covered lives to get the most out of perhaps what would be where we need to manage the care and where we don't. And most importantly, we're getting the patient more engaged than ever. There was a passivity about the patient years ago. And if we don't have a healthier population to begin with, we're always going to have a problem with costs. So diet, exercise, wellness benefits, all those types of things are critically important, and social determinants of health are also critically an important part of managing the costs and still providing care, whether it's Medicare, Medicaid, or commercial insurance.
Lynn, you make a couple of excellent points. Let me just go back to one of your initial ones, which relates to the mixed system, the public-private system. Your point is excellent that if only one half of that system, the government funded system, is all in on value-based purchasing, it won't be enough to get the response from the provider community that we need to make those efforts successful. So it calls to mind an opportunity potentially for the self-funded plans of this country, which still account for 60+% of the overall healthcare spending, to lean in on value-based purchasing and other innovations such as those that you listed to get the maximum effect in terms of system response.
Well, I just remember, Lynn, the days where, the concept of managed care, the words managed care made many, many people nervous. But now, we talk about value-based care. We talk about gain sharing and cost effectiveness and pay per performance. These are all different words for the same concept. And to your point, when Part D, when the Medicare drug benefit was being designed, you had many people in Washington, including many Democrats, who for years wanted to expand the Medicare program to include pharmaceuticals. You had many Republican members who distrusted the government provision of healthcare and insisted that any delivery model should be done through the private sector. And what do you have now? You have a Part D program that got what the Democrats wanted, which is more, pharmaceuticals, and many Republicans too, obviously wanted seniors access to this benefit, but through a private healthcare delivery model. And you see this, for example, in Medicaid managed care throughout many of the states. Medicare Advantage is the fastest growing component of Medicare. So I do think you're going to see more of this hybrid model, healthcare delivery model, where you have the government funding, but overseen, managed, and cost controlled by a private sector model.
Interesting you mentioned Part D, Ted. When I started in Medicare at Epstein Becker, one of my first projects was Medicare managed care. And it's always bothered me a little bit that CMS is a bill paying organization, not always a consumer protection agency. And when it outsources to the private sector under Medicare Advantage, it has to use a different mentality in order to do what it needs to do. I've always thought they should be two separate agencies, because as long as Medicare is a bill payer and spends most of its employee time on that, the Medicare Advantage program doesn't always get the time and attention that it perhaps needs or deserves.
Lynn, what would you say? Ted mentioned that it's all the same solutions, just with different terms, and it's maybe the jargon of the decade or, flavor of the month. What would you say has really driven some of those changes to go from, one flavor of the month to the next? Is it just it's not successful for some reason, and so we need to come up with a creative way to repackage?
Well, I think it's as much technology driven. For example, years ago, we had something called a withhold in the contract. When a doctor ordered lab services or ancillary services, a certain amount of the payment was put in a withhold pool. That was done manually and through contract provisions. And at the end of the time period, we weren't quite sure who owed who money. And we would then renegotiate the participating provider contract. Now, with technology, we don't call it withhold, we call it risk sharing. But we're in a much better situation to be able to track the costs, to be able to see who really is ordering it. But it's still risk sharing. And provider risk sharing is a way of integrating payment with provision of service. It's a matter of whether you're fully integrated or partially integrated. And partial depends upon how much risk is being shifted to the provider side of the coverage equation.
It goes back to Lynn's point at the outset about the original vision of the HMO Act to incentivize providers to make the hard choices as to what is the most cost effective care path based on their training and view of the symptoms and the available clinical care paths. That was a fundamental tenet of the HMO model. As Ted points out, we call it different things today, but that tenet remains the same. I think as much as it is driven what Epstein Becker has done for the first 50 years of its existence, I think everyone on the phone would predict we'll be at that same problem for the next 50 years.
Agree.